My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
Welcome to the DO or Do Not podcast. My name is Violet Sullivan, and I'm a pre-osteopathic medical student who was accepted and will be attending the University of New England next year for the class of 2028. In today's episode, we tackle the question of if you are interested in primary care, should you do family practice or internal medicine, and what are the differences? To tackle this question, in this episode, we called on Dr. Jill Sisselman, a board-certified family practice physician, and her husband, Dr. Steven Sisselman, who did a residency in internal medicine. The couple attended medical school at the New York College of Osteopathic Medicine, NYITCOM, and after being unhappy with their first jobs, decided to start their own private practice. They will both describe their own journeys to osteopathic medicine, the trials and tribulations of a two-doctor relationship, their experience with the couples match, and how to rank residency as a couple looking at different specialties. The Sisselmans share with us what their day-to-day lives look like and how they have made it possible to raise a family while running a successful business. We know you will enjoy this episode as much as we did.
Jill and Steven, thank you so much for being with us tonight.
Ian, thank you for having us.
Yeah,
Now,
thanks so much. We're excited.
Oh, I'm so excited to have you. We usually start with a very linear discussion, but I have some kind of offshoot questions that I'm really excited to talk to you about. And we've had only one husband and wife couple. We did them as a separate interview, but I think it's really important to have both of you on the same interview. And I think our listeners will hear why. Can you guys start by telling us a little bit about the Sisselman Medical Group and what your practice looks like?
Well, I'll take the lead on this one. So Jill and I worked for someone else in the course of our career. So from 2000, when we finished residency, up until 2008, we worked for different doctors in private practice or urgent care. And then the time came where we wanted to really open up our own venture. So Sisselman Medical Group was born in 2008. I started out. Jill actually would moonlight as a receptionist in my office. Very few people knew. We didn't let drug reps in because that would have blown her cover. But she would answer phones and give medical advice sometimes and, fill prescriptions, and people thought she was the receptionist and she was just helping me out. And once I got busy enough, Jill came and joined me, like full-time for her. She works 2-3 days a week. And it's been great, the two of us together for 15 years now in private practice.
Yeah, we really started it, interestingly enough, to be private practice for Steven. And when, like he said, when he did get busy enough and the time came to get another provider for him, it was just the natural segue, I guess, to do so. And it worked, it's been great ever since.
Yeah, we interviewed for an associate and Jill, came to interview. I'm just kidding, of course. And she was immediately hired.
That's great. So it's the two of you, the only physicians in the practice. Is that correct?
Yep. Jill and I are the only physicians, and we've grown. We started a year or two later. We added one mid-level, and then we added another. Now we have 2 offices, one in Massapequa, one in Comac, and we have 5 mid-levels and employ 27 people. So it's a big, vibrant practice, and we really do enjoy what we do.
That's amazing. So can you tell us what a normal week looks like, and maybe, what a normal day looks like, and how the two of you interact professionally on a daily basis?
So we're actually never in the same place at the same time. So that's one of the ways that it works well, and we continue to stay married. because a lot of people wonder, how do you work in the same place all day and then go home together? So the truth is that we're not in the same place at the same time. We have two offices, and we try to keep one doctor in each office as many hours as possible. So that's how that works. Each office has two providers at a time, and it's just, regular routine chronic care. We save appointments every day to be able to accommodate sick people, which I think is one of the things that people love about us. And there are days that we change the guard. We work our hours around each other. I work part-time, and initially I just fit my hours around where he wasn't. So, there are days where he'll be in the office half the day, and then I'll come and finish those hours, and he'll go to the other office, and we kind of spend whole days in one office and then swap each day so that we each get to have enough time in both offices to be able to accommodate the patients that want to see us.
Now, on a typical day, how many patients would each of you see? And can you just give me an example of maybe somebody that you saw today that you thought was a good encounter, interesting?
Well, it varies day to day, how many hours we're working, but we usually book, 3, 4 an hour. Sometimes if we're busy and we need to squeeze somebody in, we'll be seeing 5 people an hour. We'll see sick visits. We'll see follow-up visits. We'll see the routine bread and butter internal medicine, diabetes, high blood pressure, high cholesterol, COPD, allergies, asthma. We do echocardiograms in the office, allergy testing, EKGs, pulmonary function testing, hearing testing, and you never know what's going to walk in the door. And I was having this discussion with a medical student who's working with Jill right now from NICOM, or shall I say NYITCOM. I had a case of Bell's palsy, which was due to Lyme disease. And, you never know what's going to walk in the door, and you have to remember, always practice evidence-based medicine, and everything takes care of itself from there. I do believe that.
And one of the things I teach my medical students as well, and I can segue from where you said, tell me about an interesting patient for the day. Interesting comes in all different forms. So there's interesting where it's a case and an interesting medical ailment that you are trying to treat or try to figure out. Or is it a difficult patient that teaching them how to handle and how to diplomatically work with them? Or is it somebody that comes in with a litany of questions, and how do you handle that and work through those without being in the room for an hour? So interesting is all kinds of variations. And one of the things I love to teach my medical students, you can learn medicine anywhere. You can get it from, I'm going to be old school and say Harrison's Internal Medicine. You can Google any question or any treatment. But what I like to teach people, and I think what's so interesting about our practice, is so many types of people come in, and I'm going to teach you how to be a doctor and how to be a person, how to handle those people, how to deal with an irate patient, a crying patient, a terminally ill patient, and how to do an examination and treat somebody like a person and like a human. And that, to me, is what's interesting in my day and what I like people to get out of my rotation.
That's awesome. I think that's a great answer, Jill. And to kind of segue, yeah, I think when we talk about primary care so much and how important it is, and before we started the interview, you mentioning that the medical student that's with you now is thinking about orthopedics. And I think so many students are kind of led to the fact that maybe derm or ortho or things like this are so sexy, and that's kind of the high point of medicine. But I think that's so wrong. And I think primary care is so important. And I love primary care as a trained internist. But a question that I have for the two of you, and that I get asked that don't know how to answer, is if a medical student or a pre-medical student decides, look, I love primary care, I want to be a primary care doc, the choices are really internal medicine or family practice. And sometimes I'm asked, how do you decide which one you want to do? And I have no idea how to answer that. And now I have a husband and wife who, one is an internist and one is a family practice doc. Can you help us with that?
Absolutely. And that's a great question. And Jill and I might have different answers, but I'm going to go back to our roots. We trained in Delaware. I trained at Christiana Hospital, which was a level 3 trauma center. And Jill trained at St. Francis Hospital in Wilmington, Delaware. And she wanted to see some pediatrics, and she wanted to do OB and do deliveries. And I really had no interest in doing those things. And if you train in a place where Jill trained, for example, you're doing the deliveries, you're doing the pediatrics. They're not passing it off to a pediatrics resident or an OB resident. That's everything. So a lot of it depends on where you trained and you get the experience. I trained in a big power internal medicine program. So when I was done with my 3 years of residency, I could put a line in you anywhere and intubate you and resuscitate you. But if you had an earache, I wouldn't know the first thing what to do. So a lot of the primary care in internal medicine is kind of learn on the job. And yes, I did some outpatient rotations and stuff, but you don't really get enough of that to get a sense of true ambulatory primary care as a general internist. I learned that as I went, and that's the truth. Where Jill, that was her bread and butter, and her clinic hours were doing those things, and my clinic hours were taking care of these horrible diabetics and HIV patients and train wreck internal medicine patients. So it's a little different experience. Our comfort levels are a little different. I was trained really through a lot of the subspecialties of internal medicine, neurology, GI, cardio, pulmonary. I became, at least I felt comfortable and competent in those. And I think in family medicine, you're doing some of that, but certainly not as intensive in a hospital setting. Jill, does that mesh with what you think?
Like you said in the beginning, I come from a whole different aspect of it. I think that your decision on primary care will differ where you live. So if somebody's coming from New York, primary care is not the same as primary care in Colorado. So for instance, for me, it was an easy decision. I fell in love when I did my family practice rotation 3rd year. They sent me out in Woodstock. So Stephen and I chose to go to Kingston Hospital. They put my rotation out in Woodstock. And this guy was the only doctor for miles and miles. And he actually even did the surgeries. So I loved the rapport he had with his patients. I'm a people person. I love the relationship. I love the families. I love in family practice. And I didn't know that I loved OB until I did my residency. I loved that my patients were my patients. They could become pregnant. I took care of them through their pregnancy, delivered the baby, and then the baby was my patient. So in Delaware, I did everything from in utero and newborn up until geriatrics. Obviously in New York, I don't do that as much, but where Stephen wanted no part of the pediatrics, I couldn't decide between pediatrics and internal medicine. So family practice was the perfect answer for me. So I love that aspect. And I think the people who are true erudites or love the didactic part of medicine, internal medicine is going to guide them. And if they think they may want to subspecialize at one point, they should go through internal medicine. But if you love the people and the children and the family and the whole aspect of taking care of everybody, then family medicine is your choice. I still do. I don't deliver here in New York, obviously, but I still do GYN in my office and pap smears for the middle-aged person who doesn't want to have children anymore and doesn't want to go to the gynecologist. And I do the adolescents, birth control, new people at 21 to have their first pap smear and they're comfortable with me rather than going to a new doctor. So it can take on a whole life of its own if you want it to.
So Stephen, both you and Jill are making it sound like our hypothetical students should go for family practice if they want to do outpatient care. I mean, do you think that would be your advice, or do you think there's areas where your internal medicine training really shines when it comes to outpatient care?
I really like Jill's answer. I liked her answer better than mine, in fact, but I do think there's other elements to consider, right? So if you know that you want to do cardiology, or at least have an inkling that you want to subspecialize, you really shouldn't be doing family medicine. You need to do internal medicine first. There's really no natural path from family medicine to cardiology or critical care medicine or pulmonology or what you do in gastroenterology. There's a much easier path through internal medicine. So you have to think, is this something that I want to do? Do I want to be a subspecialist in medicine? And the outpatient stuff, I mean, different people have different residency experiences, right? So if you know you only want to do ambulatory medicine, I never dreamt in 100 billion years that I would be that LMD, local medical doc, that we all read about in House of God. I never thought that would be me, but that literally is exactly me. I don't do any hospital medicine. I do 100% ambulatory outpatient medicine. My job is to keep people out of the hospital. I'm the guy that I made fun of when I was a second year resident. Why aren't you coming into the hospital to admit your patients? Why am I doing it as a second year resident? So it's funny how the pendulum shifts, doesn't it always in medicine, right? And this is just another one of those times.
And I agree that I think your residency has a big part of what you do. So I only know our residencies, and somebody gave me an amazing piece of advice, and he was a family practitioner, and he said to me, if you want to do family medicine, make sure you're the only residency in the hospital. So Stephen did internal medicine. They got all of the good cases, and the family practice residents in his hospital got all of the junk that internal medicine didn't want. They had a fight with the OB residents to do any OB cases. They got very few deliveries and very few GYN, whereas I was the only residency in the hospital. I ran the ICU. I ran we called it a special care unit. It wasn't a NICU. We did the deliveries. I ran the codes. I did absolutely everything there. So I think suffice it to say, I'm an incredibly well-trained family practitioner where some others may not be. And then when you talk about outpatient care, Stephen did no general routine day-to-day sick visits in his residency, where in my residency, Stephen saw 4 patients in his 3 hours of his clinic hours.
It's true.
They would just talk a case to death, where for me, we learned how to bill. We learned how to manipulate your schedule. And if somebody was sick, you had to fit them into your schedule. And I did everything from a prenatal visit to otitis media, to diabetes, to a routine physical, to have a newborn 3-month, 6-month-old visit. And although I was learning for sure with an attending there, we didn't beat the case to death. We just talked about it and moved on in our day. So I was very prepared to go into outpatient medicine, whereas Stephen, was nervous. He didn't think it would be what he chose, as he stated. Life made his decisions for him, but he had to learn those things on the job.
That's amazing. I think my take home, and tell me if I'm wrong, is that our listeners, if they're thinking about an internal medicine or a family practice residency, they really have to do their homework and know what they're getting out of their program, right?
Yeah.
Right. You have to do your research, and sorry to jump in there, but what Jill said is exactly correct. If you're going to do family medicine, you don't want to compete with an internal medicine residency in the same hospital. And if you're doing internal medicine, you'd love to not do it where there's a bunch of fellows. At Christiana Hospital, where I trained, there were no fellows. So all of the colonoscopies, endoscopies, thoracentesis, paracentesis, lumbar puncture, you name the procedure, there was no one to pull rank over me. It was the residency program, and we did all of that, and we did plenty of it, and we were very comfortable doing it.
And Ian, I also think, people don't always have carte blanche to make these decisions. Some people need to be close to home, so they have to choose the residency program or the medical school that's near them. Stephen wanted to subspecialize, but we had a baby. So I would have had to go to work full time if he was going to continue in a fellowship. So that kind of shaped his decision. If somebody has no other outside factors forcing them, then yes, the homework is important. And to be able to do the right residency that suits their needs in the descriptions that Stephen gave and that I gave earlier, then that's great. But a lot of times people have outside forces that will guide them, and they don't have the ability to make those decisions just based on the residencies, like we said.
And additionally, Ian, there's another wrinkle. Jill and I did the couples match. So we applied everywhere from Connecticut to Baltimore, and we wound up in Delaware. Like, I don't think we really knew or thought where we were going to wind up. So that adds another layer of complexity. You really need to do your research and not apply to programs that just don't check the boxes for you. And we really got lucky at the end of the day. It may not have been where we thought we were going to wind up, but it was definitely the best combination of programs for us. And it just worked out.
In fact, it was my last choice. When I went on that interview, I told Stephen that I hated that hospital. And when we matched, I was so upset, and I remember crying about it. And I had the best 2.5 years of my life. We had so much fun. His attendings were my attendings in 2 different hospitals. They knew we were married. We had great friends. We had great pharmaceutical reps. We loved coming home and talking about our cases. I had the best 2.5 years of my life. And so you never really know what happens when you do that match.
I was recently interviewed, Jill. I have a similar sentiment. And I feel like God or the universe, or however you want to look at it, like maybe somebody's looking out for you, right?
Yeah, I think it really wound up perfect. It was a perfect place for both of us. He got exactly what he wanted and needed, and I got exactly what I wanted and needed, and didn't even know what I wanted and needed.
Exactly. The universe, maybe it doesn't always watch out for us like that, but it did in that case.
Yes.
I try to be an optimist. So
No, I love it. You need that.
Jill, can you tell us where you grew up and where you went to college and when you decided you wanted to be a doctor?
So I grew up right here in Long Island, and I knew I wanted to be a doctor from the time I was 5 years old. And there was nothing that was going to change my mind or stop me. Even when I would meet doctors and I told them that I wanted to be a doctor, just when HMOs were starting to rear their ugly heads and people would tell me not to go into medicine, I would say that there's no way that I was not going to go into medicine. I went to SUNY Albany, and when actually my sister was there as well. So she was a senior when I was a freshman. So I would meet all of the people that she knew, and they'd say, "Oh, what's your major?" I would say pre-med, and they would reply and say, "Yes, I was pre-med too, but I dropped that quickly." I said, no, I'm really pre-med. And all of these years later, when I run into those friends again, they said, "Wow, I remember that you really were hell bent on doing so. And here I am as a doctor." So I had some medical issues growing up, and I didn't like how I was treated. And I vowed to be better than any of those people were, and to take care of people and treat them with way more respect than I got treated with. And that's how I live my life and practice medicine every day.
Stephen, can you tell us a little bit about the beginning for you?
Sure. I also grew up on Long Island, grew up in Valley Stream, went to Tufts University, joined a fraternity, played rugby, had a little, maybe too much fun. I started out as pre-med, which I subsequently dropped, and became a psych major, and subsequently a clinical psych major. And I've told the story 100 times. I'm sitting in my advisor's office, my mentor. He's this prototypical clinical psychologist with the gray hair and the glasses and the beard and a pipe. And he's smoking his pipe and scratching his beard and looking at me from across his desk. And he says, "You know what, Stephen? I think you should go to medical school." And it just so happened, this is second semester, junior year. I am looking for some direction in my life. What am I going to do the rest of my life? Am I going to do a PhD program in psych? What am I doing? And I said, "Why?" He goes, "I think it's right for you. I think it's what you want. I think if you want to be a psychiatrist, you be a psychiatrist. And if you want to do something else in medicine, you'll do something else." And those words just resonated with me. And from that day forward, my mind was set and my plan was changed. I had to catch up with all of the prerequisites. I took 2 years from the time I graduated college and started NICOM. I had to fulfill all of my pre-med requirements and take the MCATs, and I was late for everything, but I got everything together, wound up at NICOM, met Jill really right out of the gate at NICOM, and the rest is history. It was really a great experience for both of us. It was a great educational program for us, and we both really loved it there.
And that's where the world had plans for us too, I guess.
Yes, excellent.
See, we're back at the universe. Steve's buying in when it comes to you, Jill. That's nice, right?
Right.
Well, something got us together. You know, I was 2 years older. We both wound up at NICOM. It may not have been the way that we thought things were going to work out for us, but this is where we wound up. And I don't think either of us would have changed anything from that point forward.
Yeah, I was going to go to med school in Israel, and I made a last minute decision to decide to go to NICOM.
Jill, can you tell us a little bit about when you learned about osteopathic medicine, and then specifically talk to us a little bit about that decision between going to Israel and staying in the US and going to osteopathic school?
So my parents had a friend who was a DO, and I actually didn't even really know much about it. I never knew he was a DO. He was just a doctor. So he mentored me to some extent, but it wasn't about osteopathy at that point with him. He was just helping me with medicine and giving me time in his office. And then when the time came to apply for school, I had learned about DO school and I decided to apply to both. And when I got into the one in New York, it was local and I could live home, and it was a good decision for me to entertain. I wanted to go to Israel to go to medicine and potentially choose to be an MD rather than a DO. But the last minute, I had financial issues and learned that you couldn't get loans to go to Israel. I would have had to pay for school myself. And I didn't have that, obviously that cash and money flow to do that, and nobody to help me. So if I went and stayed here in the United States, I was able to take out loans. So I decided to go to NICOM. The gentleman that had mentored me had a friend who had gone there and spoke very highly of it. So I decided to stay here and go to NICOM. And I loved the aspect of osteopathy once I was there. You know, a lot of things seem a little far-fetched, and everybody kind of made fun of it a little bit on the way through for certain aspects of it. But in my life, I use it all the time. If my daughter's an athlete, and there's a lot of times that I can help her pain because I'm an osteopath, and family members, things that go on, a lot of things you can fix that you don't even realize you know how to do because you're an osteopath. And I think we become better doctors in an empathetic way and a comfortable way. And I remember being on a rotation and an attending telling me this, because we start off touching people right away. Back when you and I went to school, we did OMM right from the beginning, and allopaths did just didactic medicine. So they would go into their rotations, and it would be the first time that they were coming across another person to do an exam other than practicing on whatever they did in their school. So we were constantly touching people, I think, from the beginning of time, and it just made us better doctors.
Stephen, can you tell us when you found out about osteopathic medicine and how you chose NICOM?
Yeah, it was really through the process of applying, and basically my choices were between some Caribbean schools and some osteopathic schools. I had learned about osteopathic schools the way a lot of people do, and there's different arms of medical education in this country, and I wanted to expose myself to both. And I did have to learn a little bit about osteopathic medicine along the way, but it was something that I was 100% into, and all of the theories and philosophies and whatever you want to say. The word holistic is thrown around a lot, right? Even when we started NICOM, people would say it's it's a more holistic approach. And, I didn't really understand then what that word really means until my kids started applying to college. And everyone talks about reviewing applications in a holistic manner. And only then did it really dawn on me what holistic really means. It's looking at everything. And that's really what we do as osteopathic physicians. There's not one thing. Someone comes in with an earache. It's never just one thing. People are a lot more complicated than that. And very often there's a lot of interconnecting issues and problems that people have. And very often there's a unifying diagnosis that patients will, often present with when even they're not even telling you that right away. And only through an osteopathic education, in my belief, do we really learn how to take a step back, look at a whole picture, and not just one thing. And this is drilled into our heads kind of, not only repetitively, but, persistently and continually in our osteopathic medical training. And I think it's for good reason. We're not just going to look at one thing. We're really going to look at the whole thing. And that's what I think differentiates osteopathic medicine from, allopathic. And I practice very traditional allopathic Western medicine. I do not incorporate OMM in my practice. It's not what I do. And that doesn't mean that I don't think like an osteopath, because I do. I may not perform manipulation or do structural body examinations on all my patients, but I look at it more as an approach to diagnosis and treatment. And that's the foundation of osteopathic medical care that I have always taken with me and respect greatly.
I think our trained eye is different too. I think we've looked at bodies for so long and looked at somebody who, we may not talk about in a note and say, oh, this person was side bent left, but you notice somebody's gait. You notice if they have hip pain or back pain because their shoulder is drooping, and you may not realize that that's part of your osteopathic foundation, but it is. And that makes you a better clinician and diagnostician as well. And I think again, I'll go back to when, you and I were in school, we may think that being a DO is a hindrance, but I have a lot of patients. Every new patient I say, oh, how did you hear about us? Well, I picked you because you're a DO. So I think I've heard more people choose me because I'm a DO rather than somebody who didn't want me because I was a DO. I think it's a lot more open these days. And nowadays, people don't use your pedigree as much as they used to. So again, 20, 30, 40 years ago, somebody would look at where a doctor went to school. Are they board certified? Where did they do their residency? Now, if you're in their insurance plan, that's what they care about. And if your Facebook reviews are good. So I think that people won't care whether you are allopathic or osteopathic, but the people who do care are seeking that osteopathic doctor out and know that they're a different level of doctor.
I get asked a lot of questions about osteopathic medicine and what makes us special. And I think between the two of you and together, I think if anybody has questions, I'm just going to refer them to what you just said. And anyone listening should rewind and listen about 5 more times. A couple little questions about your journey. I told you we interviewed one couple on the podcast. It's actually a husband and wife who the husband is a surgeon and the wife is an OBGYN. And they actually did not couples match. They did individual matches and kind of split up and then came back together afterward. And it sounds like through their separate journeys, it was actually a little rocky and difficult. Is that something that you discussed, or was there no question that, listen, we're doing this together? And again, as we discuss the universal, we'll figure the rest out.
Stephen, I'm going to take the lead on this one, if you don't mind, initially.
Please.
So in our schooling, Stephen is probably one of the brightest individuals that you'll come across and was top of the class, top of the boards, and really did want to be a subspecialist, I believe, at the time. And for me, I'm an excellent clinician, but I'm just not the best test taker. So I always get by and do well, but I certainly wasn't in the top 10% of our class. So couples matching was a little bit rocky, and we had just become engaged at that time too. So we were applying to all kinds of programs, and Stephen was looking at high-end programs. And sometimes when we were studying for the boards, he could sit down for 12 hours a day and literally focus and study for that. And I needed time to get up, to do something different, to clear my mind, and then go back to it. And he would be sort of annoyed that I would be doing that and felt like I should have been studying. And there was a conversation, I don't even know if he remembers this. There was a conversation that we had at one point, and I said, you're going to have to be okay with matching with me, because you may not get John Hopkins because of the program. There's only one program in each place that we were applying to. So if I didn't match in that program, now you never know who matched and who didn't. So it could have been him that didn't match and I did. But, he had to be comfortable knowing that his future could be changed because he was linked to me and vice versa. So I was okay with that and choosing our life together. And ultimately, he did decide that matching together was more important to him than the program that he was in. But for that other couple that you spoke with, their career might have been more important for them at the time. Or, there may not have been a place for both of them to go together that satisfied each of them. So that's why I said initially that outside forces can definitely play a part. So you have to really know that you want to do this together, because it can break you apart if you have any resentment in this. So, fortunately, it worked out for us. And, Stephen, I don't want to say he's made a lot of sacrifices, but I think his course changed immensely because we were together, not just in matching, but having a family and making a decision not to become a subspecialist, where he was in the hospital every weekend and never at birthday parties, kids' activities. He chose to be a family man first and then a doctor second, where, no choice is wrong, but others may say, I want to be that cardiologist. I want to be a cardiothoracic surgeon. I want to be an interventionalist. So their training, their fellowship, their hours in the hospital are what prevails. And sometimes their family is being raised without them.
Stephen, do you have any comment on any of that?
I'm just going to say that was incredibly well said. And
you resent me 27 years later?
I absolutely do not. But I will touch on one thing that Jill said about sacrifices. And when you marry someone in med school or a physician, there's sacrifices that you need to make. There's an incredible time commitment doing what we do. And not everybody understands that. And to be two physicians in the same household, you need a lot of understanding. You need a lot of patience. Even though we know what it's like to be a doctor, you don't know what the other person is going through. It's a very stressful, all-encompassing profession. And, it's very hard to leave. We're not in the ER where we leave all our cases once we punch out or our shift is over. We think about our patients and we care about our patients. And it's a very stressful and taxing profession. And whether you're a doctor or not, if you're married to a doctor or in a relationship with a doctor, you need to have a kind of understanding of what that person is going through, or it's not going to work. And, I say to people all the time, for Jill and I to be successful, we try to keep the home fights separate from the work fights and not mix those two up. And that's part of the key to our success.
That's great. And I just want to thank both of you for being so honest and so sincere with us. I think all of your points are great. Stephen, one of the things that you said earlier that I think is so important about the podcast is hearing people's journeys. So I think if someone met you and Jill and saw your practice and maybe, as Jill said, looked online at your reviews and saw how great you guys are, everything looks sweet and rosy. But sometimes there's a process to getting to that point. When you see someone that's successful, you don't see all the hard times. So you inferred earlier in our discussion that both you and Jill had a few other jobs coming out of residency before you started the Sisselman Medical Group.
Mhm.
Can you tell us a little bit about that journey?
Yeah, when we went to residency in Delaware, we really thought we were going to stay in Delaware and work in Delaware. And Jill and I were both recruited by the prominent family medicine, internal medicine programs in the area. And we could have walked into any of those that we wanted to because we were really sought out for, really being exemplary in our respective residency programs. But when we made the decision to come back to New York, we found it a little challenging to find a job. I had interviewed at a bunch of places. Nothing really felt right. People didn't know me clinically, even though we had done a rotating internship at Massapequa General Hospital. I reached out to a lot of the docs that I knew from there, and nothing really meshed. So I got a job at an urgent care center in Medford. I started my career there. I worked for a year and a half. Then I joined with a allergist internist in the South Shore of Long Island in Suffolk County. And it turned out he was writing a lot of oxycodone and Xanax and Klonopin and doing weird stuff. And I didn't really want to be associated with that anymore. I joined another group that I thought I was going to be a partner in and stay forever. But at the end of my 5-year contract, when I was supposed to be a partner at 4.5 years, the lead guy says, "I'm sorry, but we're not going to offer you partnership. And there's nothing that you can do about it." So I had no recourse. I left and started my own practice, and we saw 4 people in the office the same day, that first day. And it's been really up and up ever since. And we all really are the sum of our experiences. But when it comes to our healthcare journey, and Jill says it all the time, we really took from these experiences of other jobs. A lot of it taught me what I didn't want to do, but some of it taught me the business of medicine, the coding of medicine, the procedure orientation of medicine, doing allergy testing. You pick from all of these experiences, and it just becomes part of you. And it is what leads, at least in part, for you to be successful in your own venture. Nothing is for naught. Nothing is wasted. You're always learning. And if you take with you from the jobs that you've had, you're just going to be better going forward. And I know Jill believes the same thing.
So, Jill, Stephen mentioned also that you were a secretary in the office when you didn't have enough patients. How did you start when you came out and you had kids, and leading up to being Stephen's secretary and ultimately running his practice? No, I'm just kidding. Ultimately joining him in practice.
So I always worked part-time. I was lucky enough to work part-time so that I could be home with my kids for a lot of it. I didn't want to miss any of that. And I always knew that I was there to support him. So again, it's about sacrifices, and you can't have 2 arrogant people together. It doesn't work. So I was always happy to let Stephen flourish and do what he needed to do. And if somebody needed to stay home because of a sick kid or something like that, it was going to be me. My job, because it was part-time, I always felt was expendable, where Stephen was going to be the one, the main breadwinner and supporting the family and have a successful career, so to speak. Not that I wasn't successful, but I was content to take the hits when needed to be so that he could flourish. And I had a series of part-time jobs as well, and they all none of them didn't pan out for all different reasons. So they were stepping stones for me as well. And in one of my jobs, the boss that I had did not allow me to have a medical assistant. So I did all my own EKGs, I did all my own blood work, and it enabled me to keep my blood drawing skills up, but it also let me learn the laboratory aspect of it. I knew how to spin blood. I knew how to fill out the requisitions, as silly as that sounds, how to label the tubes, what test went in what tube. And I took all of that knowledge into the practice with Stephen. So when we opened it up for Stephen, because I worked part-time, I was able to set up the practice. I did all the legwork. I used a alias when I had to order all the equipment from Henry Schein and started the whole practice. And I would put the kids on the bus to go to school and go down to Massapequa where we had the office, and I would accept deliveries, get the phones going, installed, set up the computers, everything that I needed to do to get it ready while he worked and kept his job so that we didn't miss a beat and, we were able to pay our bills. So in the beginning, we hired a receptionist, but she couldn't work every day. So on my days off, I would be the receptionist. And it was very funny because people would call, they'd ask a question to the receptionist, and I would answer it as a doctor, but they didn't know I was a doctor, and nobody ever questioned. So if they said, well, I have acid reflux and I wasn't sure, I'd say, well, you can try Prilosec over the counter. And they'd say, okay, great, thanks. And that would be it. And they never questioned that they were getting advice from a receptionist. So we always laughed about those things. But I would go to my job and I would come back to his office and I would spin the blood for him, fill out the lab requisitions. And I never minded being in those positions because I was doing it for him. I was never arrogant that I'm this doctor and I couldn't be a receptionist or come spin his blood or send out his labs. I was teaching him how to do it. And it was important for him to build the relationships with patients and make the practice successful. So it was actually a lot of fun because no receptionist cares about making the office look good more than the people who own it. So I enjoyed talking to people on the phone, making them love the experience of the office and having them want to come to the office because their experience on the phone was so great. So how could their experience with the doctor not be great? And it just worked from the beginning.
That's an amazing partnership. That story, Jill, is absolutely amazing.
It was fun. It was a family event. My kids would go to school, and I remember at open school night, my daughter's second grade teacher saying, so I hear you're opening up your own practice. Chloe tells me all about it every day, how exciting it is. So, and I would, send out letters and I would do the EOBs in the beginning and do a lot of the billing in the beginning because, all right, so I'm a control freak, I will say that, but, you needed to have your eye on everything. Stephen and I believe that, if an owner doesn't have their eye on everything, it gets away from them and you become too dependent on other people. So every day, I would talk to my parents and they'd say, how many patients did he see today? How many patients did he see today? And the kids would come home and say, how did it go today? So it really was just a lot of fun. And it didn't matter that it was Stephen who was the doctor and I was the receptionist or sending out the letters. It was just a family affair and it was so much fun. Scary, but fun.
Amazing. Stephen, Jill, thank you so much for spending so much time with us tonight. It's been awesome. And I have one last sort of grand finale question that we ask all of our guests. And the question is, and Jill, you gave us a little piece, but the question is, what is the best piece of advice that you've been given from someone else that you really feel impacted you and that you would like to share with our listeners?
So yes, you're correct. I did answer that before. And that if you're going to go into family practice, try to make it be the only residency program in the hospital. It was invaluable. And I'm exactly who I am today because of that.
Stephen?
I think, like I've said, it's been a crazy journey and we're all the sum of our experiences. And it's been a great ride, and every day is different. Every day is fun. Every day is exciting. Every day is a little stressful, but we have our training to thank and get us through it all.
And I think I would also say as another piece of advice that no decision is permanent. So as you can see from us, we've had all different kinds of jobs. We did side jobs to make ends meet. We both did MRI injections. We both did life insurance exams, and all of that, we are the sum of our parts. So you're never stuck. I know people who have changed residencies. We've changed jobs. We've opened our own practice. We changed the scope of our practice and opened a second office. And I think that you're never stuck. So to look at everything and never feel like you can't change what you're doing and pivot your life for something that just works better for yourself, for your partner, for your kids, or anything. I think that the important thing is to be happy every day, because both Stephen and I have been in situations where we hated going to work every day and never knew when the anvil was going to drop on our head. And it's a terrible way to be. And you want to go to work as free as possible. Work is stressful. Running a business is stressful. Of course, you're not going to be free and clear, but you have to enjoy what you're doing and know that you're in it for the right reasons.
Exactly.
Guys, again, Stephen and Jill, thank you so much for being with us. The wisdom has just been ongoing, and the sincerity, and we really appreciate your time. You guys are great.
Thanks for having us.
Thanks, Ian. It was great to catch up.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.